Now we go on to Dr. Anushree, who's a consultant radiation oncologist on the home ground, that is Mahatma Gandhi Medical College and Hospital, Jaipur. So she's going to talk about one aspect that many of us face, and then we find it difficult to manage that when you have a gastric cancer which is bleeding. So she'll be primarily focusing on the role of radiation therapy for the control of bleeding from carcinoma stomach. So Dr. Anushree, please.
Thank you, sir, and thanks to the organizers. So this is a small presentation on the role of radiotherapy in carcinoma stomach to control bleeding. So gastrointestinal malignancies, they account for around 2 to 8% of the upper GI bleed events, and bleeding not only compromises the quality of life, but can also result in a life-threatening condition. So control of bleeding is very important. So let us start with a case. So a 27-year-old male diagnosed as metastatic CA stomach in January 2024 and with bone and liver mets. So he was planned for palliative chemotherapy, and after multiple lines of chemotherapy, which he received till May 2024, in June he presented to us with fatigue and blood in stool. And on evaluation, his hemoglobin was 5.8 gram percent. So he was transfused, and so his hemoglobin came to 8.3 gram percent. And then again in July 2024, he presented with similar complaints. On evaluation, his hemoglobin again dropped to 7.5 gram percent. And when we did a upper GI endoscopy, it showed an ulcero-proliferative growth in the antrum with an overlying clot. On examination, his performance status was 2. So let us discuss what treatment options do we have for him. So any patient who presents with gastric bleeding, we have 2 options, either surgical or non-surgical. And in surgical, we have palliative gastrectomy. In non-surgical, the most preferred treatment is endoscopic methods, which has a success rate of 31 to 100%. Then we have embolization, which has a success rate of 40 to 100%. And the third option is hemostatic radiotherapy, which has a success rate of 50 to 80%. Now, since there are no specific guidelines as to how should we manage a patient who presents with bleeding gastric cancer, this strategy has been proposed by Kava Beta et al. And they have suggested the non-surgical methods. So any patient who has active bleeding and has Forest 1A or 1B, endoscopic therapy are the preferred modality to treat such patients. And if it is successful, then to consolidate the gains, we can go for palliative radiotherapy. However, if it fails, then for patients who are hemodynamically stable, we can go ahead with radiotherapy. But if the patient is not stable hemodynamically, we should go with embolization, since radiation does not have immediate effect. And for patients who present with inactive bleeding, palliative radiotherapy is an option. So what is hemostatic radiotherapy? So hemostatic radiotherapy, it is a non-invasive treatment using ionizing radiation. So ionizing radiation are what? These are high energy X-rays, which are used for the treatment of bleeding gastrointestinal tumors. Now, why has radiation emerged as an alternative to the conventional intervention? Because sometimes it is not always feasible to go ahead with surgery or endoscopic methods or embolization, because the patient may be unfit for surgery, either due to comorbidities or the performance status, or the tumor is located in such a location that it is not technically possible. So, and also we know that the architecture of the tumor vessels in cancer is different from that in other cause of bleeding. So the endoscopic methods or embolization may not always be successful. Even if it is successful, patient may present with recurrent bleeding, or sometimes the equipments for endoscopy or the IR team is not available. And in such situations, we can consider for hemostatic radiotherapy. So how does radiation act? Radiation has 2 mechanisms. One is acute and other is late effect. So in acute effect, what happens is radiation damages the intimal cells of the capillaries. And we know once the intima is damaged, it activates the intrinsic pathway of coagulation. It leads to formation of a thrombus. And this thrombus then blocks the lumen of the blood vessel. And in late-term effects, what radiation does, it releases some cytokines which attracts the fibroblasts. These fibroblasts lead to formation of the fibrotic tissue. aiding in the closure of vascular defects. Radiation also kills the tumor cells, so the tumor shrinkage itself may lead to hemostasis. Now, when we are using radiation, what dose and what fractionation should we use? So there is no randomized control trial to determine the ideal dose fractionation. The treatment dose is usually what we decide is based on the patient's prognosis and performance status. And for a better patient compliance, we use the hypofractionated schedules. So what are hypofractionated schedules? We use high dose per fraction and a shorter treatment time. So these are the typical dose schedules that we use, and the most commonly used is 20 gray in 5 fraction, which is delivered over a period of 5 days, or 30 gray in 10 fraction, which is delivered over a period of 2 weeks. And let us see what is the toxicity we can expect. So CTCAE criteria is used to assess the toxicity. And the most common toxicity is nausea, vomiting, and anorexia. And in clinics, mostly we see only grade 1 or grade 2 toxicity because we are not using very high doses. And grade 3 is seen only in 0 to 20% of patients as reported in literature. The response rate with radiotherapy is 50 to 80%. As we know, it is not immediate response that we get with radiation. So the median time it takes is 2 days to act, and the median duration of response is 0.9 to 3.7 months. The overall survival, it is not impacted with the use of radiotherapy, and the studies report a median OS of 2.1 to 5.3 months. So is there any evidence for the use of radiation? So this is a busy slide, I'll simplify it. So we have plenty of studies. The data is still evolving, and most of the data it comes from retrospective series. And we have only 3 prospective observational studies which have been highlighted. As already mentioned, the dose is not standard, and various studies have used various dose fractionation. Now, how to evaluate the response? There are no standard guidelines, but in clinics, what we see is once the radiation has been delivered, does the patient require any further transfusion? Or the patient, is there any further fall in hemoglobin after delivering radiotherapy? Or does the patient need any salvage procedures like endoscopic procedure post-radiation for at least 30 days from the completion of radiotherapy? And toxicity, as already discussed, is very minimal. So in this patient, since endoscopic methods were not available, we planned for palliative radiotherapy, hemostatic radiotherapy to a dose of 20 gray in 5 fraction. So once we plan a patient, we take a CT scan of the area that has to be treated. And on that CT scan, we mark the area that needs to be treated, and we give it some margins to account for the respiratory motion and for gastric filling. After that, a plan is made in which we decide where the radiation dose will enter. And then we treat the patient on a machine. This is like linear accelerator where the patient is treated. So this patient received hemostatic radiotherapy to a dose of 20 gray in 5 fraction, and he tolerated the treatment well with only grade 1 nausea, and he had response after 3 fractions of RT. The patient was advised further chemotherapy, but he denied. So his further plan was best supportive care, and we can see on follow-up his hemoglobin remained stable. Thank you.
Thank you very much, Dr. Anushree, for covering an area which is not very easy to tackle, especially when we have gastric cancers which are fixed to the posterior apparatus and bleeding. So surgery is out. So it becomes extremely difficult because endoscopic control of that bleeding is also extremely challenging. So we have to take the help of this hemostatic radiation therapy, and you've guided excellently to all the surgeons how does it work, what does it do, and what is the outcome. Now, I will invite some questions from the panelists on this talk. Anybody would like to comment? Anybody would like to ask Dr. Anushree any clarifications or questions?
Excellent talk, Dr. Anushree.
Thank you.
I have a question. So we have given hemostatic RT to a patient. So
Yes.
you mentioned the effect lasts for up to 3 months. I mean, roughly,
Yes. Yes.
average. So if the patient bleeds again, so can we repeat
Yes, we can repeat radiation. In fact, in one of the trials, radiation was repeated within 30 days. Initially, they give 20 gray in 5 fraction to the entire stomach, and if the patient had bleeding, they again gave it partial stomach, 15 gray in 3 fractions. So it is possible to re-irradiate.
I will add it that if the patient bleeds again, then
Yes.
no, I
Yes.
mean the third time, then
So we need to see what is the duration between the first radiation that the patient has received and what doses the patient has received. Because very high doses of radiation may lead to toxicity as well. So we need to take those things into account.
but to the maximum upper limit you can consider, is it not? That's what you're suggesting.
Yes.
Of course, this will be done when, as I said, setup is such that surgery is out. Otherwise, surgery is one of the ways to control the bleeding. Even in a sick patient, ultimately it can be life-saving when the patient is. Usually carcinoma stomachs don't bleed that often. That is
Yes,
fortunate for us. But sometimes when they bleed, control becomes a big challenge. Thank you very much, Dr. Anushree, for covering
sir.
this aspect. And I think as part of it was a little bit covered earlier that what is the role of adjuvant radiotherapy, especially when you have a little suboptimal surgery. Now, before we close, I have few more questions. 1 or 2 minutes, I will ask that. One question is directed towards Dr. Kalarasan. This is from the participants on the who are watching on YouTube. So this question is related to: do you always study vessels on CT preoperatively, and your experience on kyle leak complication when you do the way you describe the dissection for lymphadenectomy with minimally invasive methods, particularly focusing on that? This question is asked. Dr. Kalaras.
So, yes, we do definitely look at the vessels on the preoperative imaging. What is relevant in gastric cancer is primarily with respect to the left hepatic artery originating from the left gastric artery. That is something which we always look, and also look at the origin of the left gastric artery. Sometimes you do have a separate origin of the left gastric artery from the aorta directly. So it's always a good idea to have a idea about the anatomy instead of having intraoperative surprises. Regarding the kyle leak, usually the kyle leak is not a major complication except when we are doing at the para-aortic lymph node dissection, or when we are doing the celiac. So the station 9, that's one area where you can get, but often it is a complication after station 16. So the important point to remember is when you do those station 16, because the kyle is primarily the lymphatic channels come from below. So you need to be careful in ligating the lymphatic channels coming from below. So if that is done, then the kyle leak complication can be minimized to a larger extent.
Thank you, Dr. Kalarasan. One last question. This anybody can answer. Like basically, when you have Sievert's tree cancer, okay, which is classified as proximal gastric cancer, what is the treatment option? I'll ask Dr. Diksha because she was talking about overall management. Dr. Diksha, please.
A slight change over there, more role of preoperative chemoradiotherapy.
No, surgery I'm asking. Question is what operation?
For type 3 Sievert. So a total gastrectomy, and proximally we take the lower end of the esophagus as much required to get a negative margin. Also, there is some role of doing maybe sometimes opening the chest and doing a adequate lymphadenectomy via the left lower thorax. But yeah, essentially.
Okay. Actually, I'm not talking about definitely mainly about the organ. Okay, so you said total gastrectomy is the primary focus, a little bit going proximally and reconstruction by with the help of jejunum, is it not? That's what.
Yes, sir.
So, look, I mean, the jejunum, rulium jejunum, or do you have a free limb of jejunum? Is there a role for that interposition of free limb in the sense with the vessels? Yeah.
So if it's a total gastrectomy, it's a row limb of jejunum. Now there is a upsurge of evidence for a double track reconstruction if a proximal gastrectomy is being done. I personally have not done. I have seen a few cases, but I have not done. So I will not put my bet on that.
Fine. Okay, I think I will close the questions here because we are just 1 minute short. And once again, I take this opportunity to thank Professor Kapoor, all the speakers who have done wonderfully today, Dr. Anushree, Dr. Diksha, Dr. Sadaf, and Dr. Kadarasan, and I would like Dr. Kapoor to make some comments. Dr. Kapoor, please, to finish the thing.
Good evening, everyone. Sorry, I could not join actively today, although I kept the uh, Zoom link on. I was just watching. In between, I had to disconnect because we had an important official function at the university, which finished about 15 minutes ago. I would like to thank Dr. Kate for accepting to moderate and conducting this session, and all the speakers and students who have joined the Masterclass for the first time. If you want to join the Jaipur surgical tutorial, which is our online education portal, you can find the information about it in one of the previous Masterclass videos. In between the sessions, I project slides which show as to how you can join. The contact details of Dr. Anand Nagar, who manages it. So with those words, because we have a convention that we start dot at 7 and finish dot at 9, I would like to thank everyone and have a good night.
Good night. Thank you very much. Thank you.